Is very important because you'll see methotrexate for lots of different things. We've already talked about it for UC. It's one of the further down. You won't see it in the first line, but it certainly can happen with UC or Crohn's disease. So it's a DMARD of choice for rheumatoid arthritis. We sometimes use it in lupus if we're trying to use a steroid sparing. So it's another one of those that will decrease the amount of steroid that someone has to use if they're also on it. In terms of its effect, I couldn't find a slide I liked, but this one is close. So methotrexate is a folate analog, folic acid analog. So why is folic acid important? You need it for what?
Neurotube.
Well, neurotube we talked about. What else?
DNA synthesis.
DNA synthesis. So any time a cell is growing and trying to move through the different cell cycles, if you use methotrexate, it will arrest it. It'll keep it from growing. And so it's been used in cancer treatments as well because it will arrest cell. It'll stop a rapidly developing cell because you'll eventually deplete its folic acid, won't be able to make the pyrimidine or purine bases. So it inhibits dihydrofolate reductase. So the folate that you take in, you can't convert from folic acid dihydrofolate into tetrahydrofolate, which is the main drug or the main folate source we're concerned about. The other is that this one down here is another drug that we can use called leucovorin. So leucovorin looks like this metabolite, and so we can also use leucovorin to prevent or decrease the toxicities of methotrexate. So when we have people on methotrexate, we will supplement them with folic acid. We can also use leucovorin to do it the same thing. If people get really toxic on methotrexate, we can put them in the hospital and give them IV leucovorin. So if you hear the term leucovorin rescue, that's what they're doing. So that's severe toxicity. So which cells are rapidly dividing? So what side effects are most likely going to be a problem from this mechanism? Gut, thank you. What else? Hair. So usually mucous membranes are a problem. Bone marrow. Okay. So those are where you see the bigger things. So stomatitis, gut upset, diarrhea. All of those can be common because of that. Look under the we'll come back to that. So contraindications. Think pregnancy. Women who are planning, so if you're dealing, and a lot of times you're going to be dealing with young women, they're going to be in the reproductive age. So women who are pregnant or thinking about becoming pregnant need to avoid this drug. If you have a man who has a partner that wants to become pregnant, you need to caution them. They recommend 3 months, being off the drug 3 months before trying to become pregnant if the male has also been on methotrexate. Very teratogenic drug. Breastfeeding, don't. Women who are taking the drug should not breastfeed. Pre-existing blood dyscrasias. So if they've already got something wrong in the bone marrow, then you are going to want to avoid this. Alcoholics. These are people who are large alcohol intake. This drug's very hard on the liver, causes a lot of liver toxicity, and alcohol will put them at higher risk for that. I moved information around last night. I meant to delete this part because I replaced it, but the adverse effects, the common ones are stomatitis, nausea, diarrhea, alopecia. For the folic acid replacement, ignore that. There's lots of different ways to go about this. I'll tell you some ways that people do it, but I've given you a different dose on the next page, so you can work that one through. Okay, pre-treatment. So what do? We'll look back on what I gave you earlier, but the one thing to keep in mind is that it will decrease people's response to a vaccination. So if they're going to go on methotrexate, you want to catch them up with their immunizations if they are behind or if they never got them. The ones to be really concerned about are live vaccines or live attenuated, because those can cause the illness, especially if you put them on an immunosuppressed. So the measles, mumps, rubella, MMR, the polio, one of the polio vaccines is live, the oral influenza, like flu mist. So be careful with the live ones, but being sure that they're up to date with their diphtheria, pertussis, tetanus, the polio, pneumovax, pneumococcal vaccine, influenza, and hepatitis B. But be careful with the live ones. So since there's more of a move, for younger kids to not get vaccinated, probably going to be more of an issue for you all in your life as a PA than it was when I was going through, okay? Everybody got vaccinated, nobody worried about it. Nowadays, people have concerns, yes.
So, what do you do if you have a patient who, because you need the DPT vaccine every 10 years, like it's 10 years later and they need it, do you take them off the methotrexate?
No, I'd have to go to the CDC website and look at it. When we get to immunizations, you make a good point. When we get to that, we'll go back and look at it. But I don't keep that information in my brain. But the CDC has a committee, the advisory on immunizations in adults and kids, and they post all of that information. So you'd probably have to go to an infectious disease expert or look there and see if you can find it. Good point, though. If you got to do a live vaccine, then there's a length of time that you would do it. Like when you get to shingles vaccine, it's a live vaccine, live attenuated. So we'll give you those websites when we get to vaccinations. Okay. So the thing I would carry away is, number one, get them up to date if they're not. Second, if you're using live vaccines, you have to be careful because you can cause the disease. The last one is non-immunized patients. So these would be somebody on methotrexate living in a household who is getting a live polio vaccine. They can shed virus and the person can pick it up. So I think those are the big concepts I want you to keep in mind, because then you can look that information up. Dosing. So the nice thing about methotrexate is it's once a week and it's oral. So like when you wrote your prescription, if you're not there yet, or y'all haven't turned that group in yet. So pick a day of the month or day of the week. So you make an agreement with the patient. So you want it once a week. Doing it once a week really reduces the risk of liver toxicity. Okay. Now, the big thing to keep in mind with methotrexate is renal function. Is that it has, as renal function goes down, toxicity will go up. So the target for most people is in that 15 to 25 milligrams per week. If they cannot tolerate it from a GI standpoint, you can give it subcute. The other issue that comes up is they don't want to inject, but they still are having trouble tolerating it from a GI standpoint. You can split the dose, but you have to take all the dose in 24 hours. So if they split the dose in half, they have to both be taken in the same day. You can keep them on methotrexate for as long as indefinitely, unless side effects or some other reason to take them off. If they stop it or you stop it, then within 3 to 6 weeks they'll start to have a flare, just to kind of give you an idea of timelines. People who take it there's lots of monitoring that goes with it. So first there's folic acid supplementation, so they must take folic acid. Different ways to do it. And the way I was taught is what I had you do your prescription. I had you write for folic acid every day except the day they take the methotrexate. The thought was that if you give them folic acid, you will overcome the effects of the methotrexate, or you will decrease its effectiveness. So I went back and looked at some information, and they feel that in the doses that we give them, which is usually 1 milligram a day, that is not enough to attenuate the effects of methotrexate. So some people give it every day and don't skip that day. So 2 different ways of doing it. The leucovorin is another way to do it. Oh, let me go back. So what do you get out of giving the folic acid? Less GI symptoms, less liver function. The stomatitis and mouth sores are usually less effects on the bone marrow. Okay, next page. So leucovorin can be used. It's more expensive. So most people go with folic acid. The folic acid is the leucovorin is 2.5 to 5 milligrams given once a week after they've taken the methotrexate. So here's one where you do have to separate it out. Leucovorin is much more potent than folic acid, so it will counteract its effects very easily. So think about that leucovorin rescue to keep in mind that its impact on methotrexate. We recommend that people don't drink when they are going to take methotrexate. If they refuse to do that, then it may be that another drug will have to be chosen. Working with patients on if they're going to go to a dinner and they want to have something to drink, that can be worked out. So you may have patients who occasionally have alcohol. That is not so much a problem. It's the more regular use and heavy use that's a problem. The last is pulmonary toxicity. You want to avoid it in people who have underlying lung disease. It can cause 3 types of pneumonitis, all of which can lead to respiratory failure. So there's 3 types of onsets. Acute is most common. Then there's subacute, then there's a chronic. You'll see that they all kind of present the same. They're non-specific, chronic cough, non-productive cough. I'm a little short of breath. Those are common. With the acute, they also may have fever, chills, or malaise, like they're coming down with a cold or a virus or the flu. They can be progressive, so asking the person each time they see them, or if they come to you in primary care, it's like, I have this constant lung problem. So keep that one in mind. Can rapidly progress to respiratory failure. The subacute, same type of presentation, just lower key, can also progress to more like pulmonary fibrosis. The chronic is over weeks and months. The others are over like days. It can occur anytime that they're on the methotrexate. So just kind of file that one away if someone comes in with nonspecific lung complaints. Pay attention to it. Okay, that's methotrexate. All right. Any comments? Stories? Okay. Alternatives to methotrexate. So if they can't take methotrexate, then usually the go-tos are the other non-biologics. So flunomide, which is Arava, is probably the #1 go-to. Sulfasalazine is another one. Then the TNF alphas, anti-TNF alphas are etanercept, which is Enbrel, or Humira, adalimumab. Other options are the ones there at the bottom, Actemra, Xeljanz, and Plaquenil. You'll note there that it says that these are effective in small trials, but they don't have the same amount of data behind them. So I would look for these to come up. Xeljanz is going to go after it because it's oral, and people are going to want to not have to take an injectable, or some people won't. So watch for those. Okay. Next page, so Arava. Another one to know about more in depth because it's common. And it has some interesting things you can do if people have to get off of it. So mechanism of action is very different. It's a prodrug, it's converted into active agent. It also is an inhibitor of pyrimidine synthesis. It interferes with a lot of different inflammatory cells, their movements, their ability to reproduce. They're just the function of all the inflammatory cells. So it's very effective against a broad swath. It's oral. One of the things you may see is that some people load the patient with 100 milligrams for 3 or 5 days and then move them to this. From what I can tell, it seems like there's kind of a movement to go to just the 20 milligrams every day, because when you put them on a load, they get much more side effects and inability to tolerate. So oral drug once a day. Under adverse effects, these are the common ones: diarrhea, nausea, elevated liver enzymes. That 3 times the upper limits of normal. Remember how you figure that? What's a normal ALT/AST? It will vary. Let's say it's 5 to 40 most of the time. It'll be some variation of that. Okay? So 3 times the upper limit of normal would be what? 120. So if they're above that, then you would do a dose reduction, or you may have to move to a different drug. Hypertension, especially if they're on an NSAID. So if this is something you're early on doing and you've got somebody who's at risk for high blood pressure, say they're overweight, they don't exercise, family history of hypertension, had hypertension that's maybe not treated, or they've stopped taking their drug. Rash and alopecia. So somewhat similar to methotrexate. Serious side effects, liver, same with methotrexate. Severe infections, it's a bone marrow suppressant. So you can see cell lines that are affected. The one to keep in mind that's different is peripheral neuropathy. Don't see that so much with methotrexate. So I would kind of learn them that here's the similar sides and here's how they differ. And it's also a pregnancy category X, means you should never, ever, ever use it in a pregnant woman. What other pregnancy category X have we talked about? One of the anticoagulants. Warfarin. Never warfarin. There was a seizure one. It'll come to you. There is. Okay, routine monitoring. That's, I heard it. Folic Acid. Okay, routine lab monitoring. CBC, so think bone marrow depression, so they're all going to pop up. Decrease platelets, decrease white cells, decrease red blood cells. So anemia, infections, bleeding, low platelets. Liver enzymes go up, creatinine, so following renal function. If they're on warfarin, then you have to monitor the warfarin more often. That one probably stands out of all the ones we talk about as an interference with warfarin. Conception. Here's a really odd, so this one you'll remember. So let's say a woman wants to come off of it in order to become pregnant. The drug stays around in the body for months to years. So the recommendation, and this would also account for like toxicities, is you give them a bile acid sequestrant, like cholestyramine. You bind up the drug, it will keep coming out of the fat more fast, but it still takes a long time to get rid of it. So if you have a woman who wants to plan a pregnancy, this is probably not one to use. Okay. Very teratogenic, so reliable contraceptive. That may mean they're on 2. May mean they're on an IUD, and I've seen women on IUDs and birth control pills. So something, so reliability. Reliability also means will they use it effectively? Will they use it as they're supposed to? So drugs can have, we haven't talked about that, sorry. Y'all have it next month, or 2 modules down. Sulfasalazine, so very effective, and it's oral. It is for people who want an oral agent. who have liver disease or women planning a pregnancy. So keep that one in mind. For the most part, fairly well tolerated, can have skin reactions, can have the same things, GI upset, leukopenia, anemia. The one thing that stands out here is sun sensitivity. Okay, so it will cause a photosensitivity rash, which can be very intense. So wherever they've got sun-exposed skin, they'll burn more than they usually would. Same kind of monitoring, and there's the dosing there. Okay. How am I doing on time? Okay. So let's look at the anti-TNF alphas. I'm not going to look at all of them. There's a chart on the next page that kind of summarizes them. The ones to keep in mind for RA are etanercept, which is Ibrel, and adalimumab, which is Humira. So those are the two that are used the most. If you look on the next page, the Cimzia and Simponi, these are newer agents. They just don't have as much data behind them. They are reasonable alternatives to the first two. Look at infliximab. Are you looking at the chart? Okay. Infliximab, if you go over to the last column, it talks about those neutralizing antibodies. So you never use infliximab as a monotherapy. It has to be used with like methotrexate. You can use multiple non-biologics together. You don't use multiple biologics together. So you can use methotrexate, hydroxychloroquine, and sulfasalazine together. You can do those three. And sometimes they do that. So you'll see Ibrel is an injectable. Humira is an injectable every other week, so some people prefer for that. Cimzia is also an injectable. So everyone in that group are injections. If you look down through their adverse effects, it's similar. Infections. You'll see you'll see cancers listed also as common. So the reason why Ibrel and Humira are considered the first line is because of evidence. All right, out of that group. Look at the next page, 15. There's another chart. These are the non-TNF alphas. The two to pay attention to are the ones at the bottom, Actemra and Xeljanz. So those are the two that have data behind them that says they're effective. It's just not as much data or experience with them as there is with methotrexate. Look at know the mechanism of action. Know that Actemra is an IL-2, interleukin-2, and that Xeljanz is the Janus kinase inhibitor.
You mean IL-6?
Sorry, whatever I said, yes. Questions? You'll see the first three are IV, last one is oral. So there's going to be a lot of drive to go that way. Questions about those drugs? Yes.
So you said it's IL-6 or IL-2?
IL-6.
Okay, that's what you're sure.
It's IL-6. Okay, lupus, page 16. So lupus, another autoimmune disease, can affect the skin, can affect, it tends to be very, more organ dominant, like it can be, you've talked about kidneys, lungs, pneumonitis, both of those are very common. Cerebritis is very common as well. Joints, so people can have just joint. They can have just kidney, just lung, or they can have joints and kidneys. Okay. Lupus nephritis is very common and requires a lot of aggressive treatment. So let's kind of go through these. For mild treatment, oh, let me back up. So there are different types of lupus. There's a discoid lupus, which is mostly skin. A lot of our drug reactions that say lupus-like, it's usually discoid. That's the skin manifestations. So hydroxychloroquine is the drug of choice for mild lupus. That's where we start. So think baseline needs for that, and also think cumulative dose, think retinal toxicity. Also, it would be common to use steroids in hydroxychloroquine, especially for more advanced disease, or when you're starting out. If you look on the next page, a little bit more on Plaquenil. Also one of the few drugs that is safe during pregnancy. For women who have very limited, and I'm switching back to RA, for women who have very few joint involvement, mild disease, low disease activity, no poor prognostic indicators, you could consider hydroxychloroquine as a drug of choice in them. Very small number of people are going to fit into that, okay? So there is a place for them. Adverse effects, very similar to what we saw at the other. Rash, GI, but the eye is different. So remember the cumulative dose, 6 grams. 6 grams per kilo. So you're going to keep track. If they are on this, they're keeping track of that total dose. Baseline eye, periodic, depends on age, other underlying eye disease. Mostly affects the retina, but it can also affect the macula and destroy it as well. That biologic DMARD it's gotten separated from its definition there. So I've talked about the biologics versus the non-biologics. It's a little piece of information I had moved and didn't delete from that section. So sorry, it just sticks out as odd. At the very bottom and on the next page, it talks about patients who have extra articular manifestations of SLE and what do you do about those. And it mostly focuses on the use of high-dose steroids. On page 18, so there's other immunosuppressants that people may use. You've seen these before. We talked about them under ulcerative colitis and Crohn's disease. So mycophenolate, cyclophosphamide, those often are used to induce remission. Going down under NSAIDs, you're going to use them similar to what we did in RA, so it would be early on. Or when people have arthralgias and you're using it for periodic or short term. They do not suppress disease activity, just like with RA, so we don't want to use them all the time. We're only going to use them when we need them. Adverse effects, same as with any other time we've discussed them. One thing to keep in mind, since kidney is a problem, and it's often a problem in young women, avoid the nonsteroidals in women who have lupus nephritis. Corticosteroids. So some women are maintained on low doses of this. This would be in that 5 to 10 milligram per day or every other day. Sometimes we can move them to an every other day dosing. So this is women who don't get a full response to Plaquenil or other agents. When you've got moderate to severe flares, again, just like we talked with RA, you would use a burst or a time of steroid use. Significant organ involvement, especially when you're talking about either pneumonitis or nephritis, they're going to use steroids, probably higher dose, with a steroid-sparing agent like azathioprine or methotrexate. Azathioprine is underneath there. So one of its problems is the length of time it takes also to exert an effect. So that's why you would use something like the mycophenolate or the cyclophosphamide to get remission, and then azathioprine long-term to maintain it. Again, often used with steroids to decrease steroid amount required. Similar type of toxicity, so it's repetitive, GI, bone marrow, that we see over and over again. Mycophenolate. We'll see these in lots of different diseases coming up when we get into skin as well. Very effective immunosuppressant, again, mostly for lupus nephritis. Cyclophosphamide, another. Mostly these I want you to just have an appreciation for what they are and where they would fit. So cyclophosphamide, immunosuppressant, usually used with the lupus nephritis. The very last drug is Benlysta. It's a targeted, it's one of the few of the biologics that we have for SLE that is targeted. And it is in its specific, has a very specific definition for active autoantibody positive SLE who are also on standard therapy, steroid, azathioprine, hydroxychloroquine. Limited to patients with active musculoskeletal or cutaneous disease unresponsive to standard therapy. Dose, you don't have to know dose, but just to show you, it's every 2 weeks for the first 3, then every 4, so a monthly dose. African Americans, very high incidence of lupus in African Americans. So I think that's why they're pointing that out, is that this hasn't shown well in studies, or they haven't been enough of a subgroup in studies to demonstrate effect. Side effects very similar to what we see with the others. And then you see the serious side effects, anaphylaxis, infusion reactions, which you can get with almost anything you inject, and serious infections and malignancies, which you will see with any of those agents that are above there. Questions about those? Okay. 21 is a repeat. I didn't delete it when I moved it. So that safety issues in monitoring, this page, on page 20, that is a summary. To me, it's an important one because it helps you to know what you're going to monitor throughout therapy, and what do you do before. So that first, that obtain under B, is what I gave you at the very beginning. So the CBC, liver, kidney, Hep C, Hep B, HIV status would be another one. It doesn't show up in some of the guidelines, but you do see it in some of the immunosuppressants, so keep that one in mind. Especially if you've got somebody that you detect Hep C, and remember when we talked about Hep C, we talked about always check Hep B status and HIV status because they're common. Same would go with TB. If they're positive for TB, look for other immunosuppressive or other diseases like that. Lab repeats are frequent. That's what I would remember. Frequently meaning early on, every 2 to 4 weeks. Then as people get more stable, they might go out as much as 3 months. Keep the platelets and the white blood cell counts in terms of methotrexate and luflanomide. It's easy to think. Bone marrow suppression, there is a definition for when to stop the drug. Contraindications, so sulfasalazine and platelets. Don't start them if the LFTs are more than 2 times the upper limits of normal. So if you've got liver disease, you're not going to start those drugs. Acute Hep B or C contraindicated in all the DMARDs except hydroxychloroquine. If they've got an ongoing infection, you're not going to start these drugs, right? No brainer. Withhold biologics 1 week prior to surgery, 1 week post-op. Moderate to severe heart failure, contraindication for the TNF Alpha blockers. Mostly you're dealing with younger patients, so that may not come up as often until you've got folks who've been on it for long periods of time. Renal insufficiency, keep in mind Arava and Methotrexate. Pregnancy, same too, blood dyscrasias, Methotrexate. If you kind of look at their overall, what's the contraindications, what are the major side effects, what do I need to know ahead of time, these all make sense. They should flow out of what you've already learned. Vaccinate patients. Hep B for all people before they start the DMARD. Influenza, if you're going to inject, they're going to get an injectable flu vaccine, it's not a problem. It's those flu mist, which we don't use anymore. Haven't had them around for a few years. Pneumonia, getting the Prevnar 13 Pneumovax. Okay. Think about the underlying lung, like with Methotrexate. Human papillomavirus, that's kind of a newer one. And herpes zoster, that is a live attenuated. So it says wait at least 2 weeks after zoster vaccination to begin the biologic. And then don't give live to people on DMARDs. Okay, so big concepts, big stuff. Okay, so I only have 8 to 10 questions. So if you write in your test on Monday.
Yeah.
So the big things that I drilled home all the time, you should pay attention to. All right, good luck, have a good weekend.
Thank you.